Okay, so first of all, a big thank you to organizers. It's amazing that this is happening. I feel very honored to be presenting here today. And I also want to declare that there is no conflict of interest in my case. So, this is the agenda for the coming 20 minutes. I want to talk about the PSIPET study, to introduce you to clinical research in this domain and the nitty-gritties and the problems that we encounter while doing this kind of research, and some learnings from that. And then I want to switch to talk about depression in young people, because that is something that has not been targeted yet by psychedelics. And then also about a group program where different altered states of consciousness are already implemented without psychedelics, and how that can be preparatory to introduce psychedelics later on, which I think would be amazing. So that's the last thing I want to speak with you about. PSIPET is actually the effect of psilocybin on major depressive disorders, symptom severity, and synaptic density. So the aims are twofold. It's phase 2b study, and it investigates both the clinical efficacy of psilocybin on depression, and it's also a proof of concept study, and I'll explain a bit more about that. And the design is a randomized controlled trial, and it's a 1-to-1 allocation ratio, and it's double-blinded. And people are then participating and being randomized to either receiving the active drug, psilocybin 25 milligrams, or a placebo, a B vitamin dose. And this study targets adults, so the participants are aged 20 to 65. And the target is to recruit 30, and we have now dosed 27, so we are close to do full circle with this study. And they will have to have the diagnosis of major depressive disorders and mainly otherwise healthy. No other current treatments with antidepressants or psychotherapy, of course, and naive to psychedelics. So this is a little bit about the target population of the study. And the outcomes, we have heard it's similar to what has been presented here before. We used the Montgomery-Åsberg Depression Rating Scale, and the difference between the two arms in change from baseline and to day 8 in total score. And this is a clinical assessment. MADRS can also be administered as a self-assessment, but we have the clinical assessment as the primary outcome. And then we have secondary outcome, and that is actually the most important part of this study, which is very biomarker heavy. So we use PET scan, positron emission tomography, and with a specific radioligand, we can get a measure of synaptic density in the brain. And why then is this interesting? Well, it shows that MDD patients, they have a decreased number of synapses in different regions of the brain, and cortical atrophy. And also, preclinical models have shown that substances that hit the receptors for the 5-HT2A, such as psilocybin, they can restore this. They can induce synaptogenesis and also increase neuroplasticity. And if we can show that this is the case, that the antidepressant effect is actually mediated through this mechanism, we have proved a mechanism of change with psilocybin, which is a relevant question to ask. We have heard today several hypotheses already presented of why these substances might be effective, everything from anti-inflammatory, etc. So this would be another mechanism of change. And then we also have, as I said, a very biomarker-heavy study. So we also look at blood draws and cerebrospinal fluid and a lot of self-report scales, and of course also safety and tolerability data. And adding to the PET scans, there is also functional and structural neuroimaging and both for structural data and, for connectivity data and for more functional paradigms. So it's a lot. And the way it goes is that all of these data is collected at baseline. And then when this is done, the participant get the first prep session with 2 facilitators to get to know the facilitators and get some information about the study. And after that is done, the participants are randomized to these 2 different conditions. And day 1 is the dosing day. We have already heard Professor Licht talk about how that works. It's similar for us. And then there are the day after again, an integration session, number 1. After a week, another 1. And then at day 15, all measures are repeated. So the patients have to go through all these scanning and lumbar punctures and self-report. And then the last integration session, and then follow-up day 43. And after a year, so it's a long study period, it's 1 whole year. And that is important, of course, to see how the duration of the potential effect, to have a long period. And it's also complicated, because think of the placebo participants here. They don't get much treatment for their depression for 1 whole year. We do have a minimal set and settings protocol. And this is designed primarily to enhance patient safety. So similarly to what Professor Licht was talking about, this is not a psychotherapy study. It's not that we are looking into what modalities of psychotherapy could potentially support psilocybin administration for depressed people. No, this is simply to keep it safe. The protocol is identical, of course, for the 2 arms. And the facilitators were trained by Umeå Institute, a quite brief training. And the same 2 facilitators are present for all the sessions with the patient. And in the training, they are basically encouraged to behave in a non-directive and mindful way, which is a bit brief. Room for improvement. So my reflections, and this is my own reflections. So I think there are in general problems to design RCTs for these kinds of substances, honestly, because the blinding, as Professor Licht also mentioned, is not 100% effective. Most people know whether they have received 25 milligrams of psilocybin or not. And maybe not everybody, but most. Of course, the ones who've gone through this lumbar puncture and all the scans and all the assessment forms and hope to get help, they're going to be very disappointed when they receive placebo. And could we potentially have a nocebo effect from that will explain some of the results? This is a problem. The biomarker heaviness of this study I've already discussed, and the lack of standard treatment during the study period, or not only standard treatment, but any support provided from the study personnel is prohibited. Also, one thing that I really want to highlight here, and Dr. Kwam was talking about the overlap of traumatic incidents, adverse life events, and the onset of depression. We did not do any specific screening for trauma or for dissociation. I think this is a huge loss. Because I'm a child and adolescent psychiatrist, I see many young people with depression, and when I ask them about trauma, it's almost everybody who's been quite heavily traumatized during their lifetime. So my question is, are we really treating depression here, or are we treating dissociative states, like a dorsal vagal shutdown that can be chronic? And in that case, no SSRIs or CBT will help, because it's something else that we should treat than the actual depression. So this is really important also from patient safety, because if you are dissociative or traumatized and get psychedelics in high dose, there's quite a risk for re-traumatization, and this is not well acknowledged yet. Maybe they should have MDMA instead. The therapists were stressed because they didn't feel, some therapists were stressed for some patients because they felt that the patients didn't get enough support. And of course, we also noticed, and we knew this from beforehand, that depressed patients are often socially vulnerable and lack support systems. And it's not only that they lack support, but having had a transpersonal mystic experiences and then coming home and have nobody who understands what that is a lonely place to be, whether you're depressed or not. So this is also something that I think could be addressed in different ways, in groups, supports, etc. in the future. And the therapists, some of them did, some of them did not have experiences of working with altered states in therapeutic settings. And I think that would be a huge advantage, whether that is with psychedelics or not, but just understanding the complexity of that. And now I want to spend the last part of my talk here to apply these learnings on the target group of young people with depression. Because we've heard about treatment-resistant depression. All these studies that are ongoing are targeting people up to 60 or 65. And the actual data shows us this specific graph here, disability-adjusted life years by age for each mental and substance use disorder. And you see that that blue line that peaks up here, that is depression, which is way more common than the other mental disorders. And it's not that it's the old people who have the highest prevalence of this disorder, it's the young. It appears to start in the late teenage years and peaking up into young adulthood. And we have no effective treatment to offer. We heard here from previous presenters that SSRIs and CBT and all these so-called evidence-based methods lack efficacy or effectiveness, and it's even worse for this age group. Also, SSRIs have more severe side effects, and it's often very hard to taper those medications. So people get them when they are 16 and continue for 10 years on SSRIs, with all side effects that is. So we clearly need a way to address this. And to do that, and to draw from the PSIPET study and other studies that are ongoing in the psychedelic field, I would want to target the young adults where brain plasticity is actually peaking and we have a chance to prevent recurrent episodes. That would seem to me the most smart thing to do. And then I would carefully screen for dissociation and trauma, and I would create a group support where altered states of consciousness are being practiced, so that that's not completely new when you take the psychedelic drug, but you actually know what metacognition is, you know what an altered state is, and you feel comfortable navigating these spaces a little bit. And also, in the group setting, increase the amount of preparatory work and integration possibilities. Also, specifically look at communitas. Look to what that group is experiencing together and how that can be a support in the future and how that relates to the antidepressive outcome, I think is really, really important also. And potentially giving 2 doses of psilocybin with a lower dose for the same rationale as for introducing other practices of altered states to get a little bit familiarized so we don't re-traumatize people with a sudden high dose with no understanding. And I wish to do a really carefully planned pilot study on this first and assess also with qualitative outcomes, because I think people have a lot to tell us from their subjective experience and how they would guide us in the future to design these studies. So it's not only these pre-constructed assessments form where we get answers from however we ask. And then more comprehensive training of the facilitators also, ideally with their own experiences of working therapeutically with altered states of consciousness. And the good thing about this is that this group intervention is already there. This is what I've been working with for perhaps 10 years or so. And we have named this intervention TARA, which stands for Training for Awareness, Resilience and Action. And it draws on all the neuroscience that we know of with regard to depression in the developing brain. So even the young adult brain is still under construction, and the neuroscience implicated is very different from depression in adults and elderly people. So one example is the limbic system, the amygdala, which is hyperactive in adolescent depression. And also, you probably all know that the prefrontal cortex is not fully developed until mid-20s or maybe even later. So being a depressed teenager, it's very difficult to top-down regulate, to use cognitive reappraisal, to tell oneself to feel better and cheer up and things like that. It just doesn't work very well. Also because the limbic system is so active. And also the reward systems work differently in the developing brain. So risk-taking behavior, anhedonia, drug abuse, and all these kinds of things play out differently in this age group. And the functional and structural connectivity between those emotion regulation areas in the brain are affected in adolescent and young adult depression. So these brain areas do not speak as well between each other as in a non-depressed person. So we designed Tara to actually target these different brain regions and see if we could create brain change through practice of all the states of consciousness, actually. And first, we wanted to use bottom-up approach instead of top-down approach to decrease the amygdala hyperactivity. And we did that, we borrowed from yoga. So we did pranayama, breathing techniques, slow synchronized movements. We also did sensory activation with tapping and bilateral stimulation to calm down the system. And what we do here is actually to bring the person out of default mode network by putting their attention to something else. So it's a bottom-up approach. In module 2, we practice more, and this is actually pure mindfulness expressed in neuroscientific terms. It's using metacognition to notice that you speak badly about yourself, and then intentionally direct your attention to the breath, for instance, or something else. How does my feet feel when I'm standing here? Interoceptive awareness. Then we activate the salient systems and the anterior insular cortex instead of the default mode network. This is a skill to be practiced. And then, module 3, we practice relational skills, empathic communication, practices of self-compassion, compassion towards others, and also bring in a systemic perspective on depression, which I think is completely lacking in normal therapeutic clinical settings. So if the depressed person, or I, is the red dot, I'm surrounded by my closest people, and then there is my school or working place, and then there is the bigger community, and then is the world, where there are geopolitical conflicts, and there is corona pandemics, and there is climate change, and we have systemic ripple effects that affect the individual. And this is being named and actually addressed in these group sessions. And often people say that this is the first time that this has been mentioned in the therapeutic sessions. And I think this is also really relevant, talking about psychedelics, because it is about seeing the world with different eyes. And this is also preparatory work to look at oneself in context. Depression is a disorder of disconnection and loneliness often. And by being in a group and naming these things and understanding how things connect is also something that prepare for the psychedelic experiences to land well. And then in the end, we put all of this together the last 3 weeks. So we talk more about what is the meaning for you? How do you want to create a life that matters? And they can use all the skills that have been acquired throughout and put action to themselves. And this is very much inspired from Stephen Hayes and acceptance commitment therapy. Some of you probably recognize this kind of reasoning. And we have done a lot of research. Most of it is happening at UCSF in California. So the mechanism of change are published. A first clinical pilot is also published. And that went so well, so we got funded by the NIH to do more of proof of concept studies. So there are some articles published for those of you who want to know more about those brain changes also. And at the moment, we are looking to test TARA versus standard treatment, which is SSRIs and CBT normally in Sweden at least, to see which works the best. And the protocol for that study is already published, and we are piloting the sites where we're going to recruit from. And it's happening at Umeå University, where I am working at the moment. And just to say something about my future dream study that I would like to do, because that would be to combine these two treatment modalities to one and test that. So having those 12 group sessions, 2 facilitators, 12 participants for 3 months, coming together once a week, go through the TARA program or a modified protocol, and then give them a psilocybin experience, maybe after session 8 or something like that. So there is still time for integration and the meaning-making part of that protocol. And then, if that goes well, of course, also assess it in the standard way we do assess clinical efficacy and effectiveness, and that would be in an RCT design. So it could be, for instance, TARA with psilocybin or TARA without, to see what is the psychological component and what is the medical component in this. Or it could be similar to what we do now in Umeå, to test TARA with psilocybin comparing to standard treatment. Or I have to discuss also with Dr. Kvam here if we should compare psilocybin and MDMA in some ways. And this could be potentially multi-center design, so if anybody is interested to speak about this with me, please approach me here in the pauses. I also want to say before I stop that the PSIPET study, I'm not the principal investigator, I'm more in the periphery of the study. I've been supervising the therapists, and Johan Lundberg is the PI, and Maria Beckman and Michael Tiger are co-PIs. So I'm on the co-investigator side. And there are many people involved, of course, in the TARA projects also. Thank you very much for your attention.